So thank you for asking me to come. It's a real compliment when Susanna and Imogen think that you actually make enough sense to come and talk to a patient conference. So really happy to be here. Let's see if we can work the tech. So I work up at number 2, that's Lancashire and South Cumbria Cancer Alliance, just sort of where the 2 is, that's Preston, which is the cancer centre for Lancashire and South Cumbria, and I lead the skin cancer service up there. So what I'm going to do, I'm aware that for some of you, you've had immunotherapy, you've done a lot of Googling, you've researched it, you know more than I do, and for other people, it's your first conference, you're not really sure what we're talking about when we talk about immunotherapy. Now, Yin very helpfully has covered some of that, but we'll just briefly bring everyone up to speed, talk about why we like immunotherapy for melanoma, what the toxicities are, and then sort of get into the meat of some of the issues with having had immunotherapy and what that can mean for you long term, and what we're going to do about that, where to get information in 25 minutes, Imogen Cheese. Maybe-ish. Anyway, so if you have a cancer, it produces cancer antigens, so it produces protein that identify it as a cancer. And if you follow the little clock around, you'll see that your immune system should find those cancer antigens, see them as not you, tell your immune system to get rid of it. Your T cells whiz around to your tumour, kill your cancer, just like it would kill a virus or a bacteria. So in that sense, having a cancer is a failure of your immune system, and I think you've heard that a little bit today. And when we talk about immunotherapy, there are lots of different types of immunotherapy, and the first talk really elegantly explains some of the different ways that you can manipulate the immune system to try and target cancers. When we talk about immunotherapy generally in the clinic, though, we're talking about ipilimumab, pembrolizumab, nivolumab. We're talking about the monoclonal antibodies and checkpoint inhibitors. So for the purpose of this talk, when I say the word immunotherapy, I'm talking very specifically about those checkpoint inhibitors that we have available for us in the clinic. And so I'm just going to show you a little video. I feel like I'm echoing. I'm going to show you a little video that's going to just bring everyone up to speed about how these work and hopefully reinforce some of the things that you've heard already.
Immunotherapy is an exciting area of cancer research that is changing the way we think about cancer treatment. Immunotherapy works by using the body's immune system to fight cancer. The immune system is a complex network of organs, tissues, and cells, and the substances they make. Immunotherapy uses different ways to boost the immune system to do a better job of killing cancer cells. This video describes one type of immunotherapy that uses immune checkpoint inhibitors to treat cancer. T cells are a type of immune cell and are powerful weapons the immune system uses to fight cancer. Immune checkpoints on cell surfaces help control an immune response. Usually, immune checkpoints keep T cells inactive, that is, in an off state, until they're needed. This keeps the T cells from harming normal cells. Cancer cells can take advantage of these checkpoints to switch T cells off. This keeps the cancer cells from being killed. Immune checkpoint inhibitors are drugs that block the checkpoints. This frees the T cells to attack the cancer. Immune checkpoint inhibitors are an effective way to treat some types of cancer, but they don't work for every patient and can cause serious side effects. To learn more about immunotherapy, visit cancer.gov.
Okay, so hope we're all up to speed. So we want your T cells to stay active, and the 2 main checkpoints we're talking about are CTLA4 and PD-1. Now, I just wanted to highlight the fact that this has been such an amazing change to how we think about treatment for cancer and how we treat cancer, that James Allison and Takuji Honju won the Nobel Prize for Medicine based on these discoveries. This is a big deal. And these drugs are now used in almost every cancer. There are different types of PD-1 antibodies, PD antibodies, et cetera, and you can use them with chemotherapy. Now, we're not being politically correct that this is a lady, because unfortunately the one cancer that seems to be fairly resistant is prostate cancer. But in almost every type of cancer now in the clinic, available on NHS, there is an immunotherapy for many types of cancer. But melanoma remains the poster child for immunotherapy, absolutely. We started using it many, many years ago, and it is still really the basis of our treatment for melanoma. This is just really emphasising how amazing this has been. So this is a headline from 2024. So more than half of patients with advanced melanoma who are given combination immunotherapy will survive their disease for at least 10 years. This is incredible. When I started treating melanoma, it was essentially a death sentence, and all my patients died within 12 to 18 months. It was awful. And so to now be in a position where we can use the other C word, the cure word, and I do use that. I know not all my colleagues do, but I was interested that the cure word came up in talks earlier, that we are curing people with immunotherapy. And because of the success treating patients with advanced disease, we now are using that in the adjuvant setting. And thanks to Susanna, you all know what adjuvant treatment means now, so I don't need to cover this slide in any great detail. But these are slides from the Melanoma Focus website, showing you that on the left there, you've got a lot of yellow people whose surgery has cured their melanoma. Surgery is a brilliant treatment for melanoma. But unfortunately, there are some people where the cancer comes back. And if we move on to the next panel, if you're given adjuvant treatment, so you're given treatment after your surgery, that improves the number of people who are now yellow and cured. The important points here are that a lot of people then got that treatment, they didn't need it because surgery was enough. And unfortunately, some people got the treatment and it didn't work. And at the moment, we don't have a way of saying, you've had surgery, you're fine, off you go. You've had surgery, but you need the treatment. You've had surgery, and actually we need to do something different because immunotherapy doesn't work. And that's important when we're talking about side effects, because all those yellow people had the treatment, put themselves at risk of side effects, and they didn't need it. So when we're talking about side effects coming into the next 3 slides, just bear that in mind. So this is a talk about side effects and toxicity. I just want to say again, immunotherapy is amazing. Don't listen to this and think, oh my God, it's so terrible, I'm never going to have it, because I'm going to make it sound pretty awful for the next few slides, because I'm going to tell you all the things that can go wrong. So just bear that in mind. So first of all, what is the toxicity of immunotherapy? So if you have got, I'm going to explain it as I explain it to my patients, I don't use very big words. If we are getting your immune system to ramp up a bit to find melanoma cells, it can get a little bit overexcited, a little bit confused, and it can attack other parts of the body. So it can attack anything. And you're seeing here basically arrows pointing to every single part of the body. And if you sign the consent forms, the CRUK consent forms for immunotherapy, you will know it is just a list of every single part of your body. And if you pick a part of your body and say itis after it, so skin, dermatitis, liver, hepatitis, you have described a side effect that we have seen and has been recognised. So some are more common than others. So skin rashes, joint pains, colitis, inflammation in the bowel causing diarrhea, hepatitis are more common. Some are less common, some inflammation in the nerves, myocarditis, which is inflammation in the heart, are less common, but as you can see, are more serious. And unfortunately, there are some patients who die because of the side effects of immunotherapy. It's not common at all, but it can happen. So those are the side effects. How common are they? How likely are to get a side effect? So I'm going to put some red circles around some of these numbers, so don't worry about trying to look at everything. But this is the Checkmate 07 study that compared ipilimumab, so CTLA-4 antibody, pembrolizumab, PD-1 antibody, and then the two together. And so it just is a good example of being able to compare those. So if you just look at the numbers in circles, so that's the number of patients, the percentage of patients who've had these treatments who had a side effect. So it's almost 100%. It's a lot, isn't it? So almost everybody notices that they're on immunotherapy. Now, I would say a lot of the time it's I feel tired. Or I've got a little bit of skin rash, and it's nothing major, but pretty much everybody notices they're on it. What becomes more difficult is when you're looking at grade 3 and 4 toxicities. So these are the toxicities that probably need treatment, that you might be in hospital for, that you might need to delay or even stop your treatment for. And you can see there that with one drug, around maybe 20-30% chance of getting a toxicity, and then I remember when this trial was presented at ASCO, and there was a gasp of horror as we all realised that when we use two drugs together, we get really good responses. And as I said to you before, over half of the patients will live for more than 10 years, but there's a trade-off. Nearly 60% of patients with combination treatment will get a significant side effect. So again, don't be scared. Don't be scared. It's a great drug, the great drugs. If we just look at this, when do they happen? So if you have chemotherapy, you have the chemotherapy drugs, you can be pretty certain that if you're going to feel sick and if you're going to vomit with the treatment, it happens in that first cycle. And if you're all right with your first cycle, you'll probably be all right. If your hair is going to fall out with chemotherapy, it'll happen about 3 weeks later. Things like that. With immunotherapy, just because you've been all right with your first dose, it doesn't mean you're going to be all right with your third dose. It doesn't mean you're going to be all right 12 months later. And what this is showing you, and again, big long list of side effects, you don't need to know the details, but a big long list of different ones. Within the first, what you're seeing is that the circle showing you the average with the long sticks showing you the earliest point somebody got a side effect and the latest point. So some of the side effects happen earlier, some of them happen later, and you're looking at 300, 400 days after having had a dose of treatment that people are still developing new side effects. So the side effects can happen later on. And this study is from, why am I not seeing it? This study, sorry, I have to turn around, it's not appearing on my screen. So this study was supported by Melanoma Focus. It brought together some data from 3 of the big centres in the UK. And interestingly, they found that about 15% of people had a side effect 3 months after they'd even stopped the treatment. And a small number of people, I think it was about 5 or 6 people in total, so 2%, had ultra late onset. So IRAE is an immune-related adverse event over a year after they'd actually finished their treatment. So that's pretty late. So one of the challenges is for you guys and patients to realise that what's wrong with them might actually be due to something they had over a year ago, and trying to convince your doctor that the side effect you're having might be related to treatment over a year ago, because that's quite unusual, can be quite challenging, and that's a challenge we have together. So I'm telling you that these side effects can happen later on. The other slight issue is that these side effects can also stay with you. So just concentrate on the yellow and green. So what the yellow and green is showing, again, big long list of different side effects. The green are the people that got better, but the yellow bars are showing those side effects that didn't go away, so that were permanent. Now, the longest yellow bar is vitiligo, so whitening of the skin, which a lot of people don't mind so much, but it can be quite disfiguring. But things like 25% of people who get a peripheral neuropathy, so tingling in their fingers, doesn't get better. You're living with that. And as I said before, remember, if this is in the adjuvant setting, you might not have even needed that treatment. So these are really important things to remember. And we talked about the fact that we have serious side effects, so grade 3 to 4 side effects. We pooled our data with Bodhi, who works in Belfast, to show that even as doctors, we often talk about low-grade side effects, manageable side effects. But actually, even patients who have these low-grade side effects, it really affects their quality of life and has a significant impact on them. So we pooled our data together of patients who'd had immunotherapy in the adjuvant setting. Again, remember, they don't necessarily need this treatment. It might not be a benefit for them. And a number of them, 15% of patients ended up having to come into the hospital to treat their side effects. A third of them had the treatment stopped because of this low-grade toxicity. And about a third of them needed steroids to treat the toxicity. We've not talked about treatment yet, but just to be clear, we often give patients steroids when they're on immunotherapy to try and treat the toxicity, and I'll come on to that. So, what do patients actually think about their side effects? So this is the Dante study, and some of you may be aware of this. It was a study to try and reduce the amount of treatment that patients were receiving if they had metastatic disease, and you were stopping the treatment early. Unfortunately, it didn't recruit to its full numbers, partly because COVID hit, and that wasn't very helpful. But they did manage to do a little sub-study where they asked people what they thought about being randomised to carrying on treatment and stopping treatment. And they found that a lot of patients actually downplayed the effect of the side effects on their life. And I think it's quite fair to say that, well, don't stop my treatment, it's working. Don't stop my treatment, I don't care that I've got a skin rash and I'm taking a thyroxine tablet. What, are you mad? Don't stop my treatment. So a lot of people played it down, and the focus very much was on not stopping a treatment that was working. Now, I'm not saying that therefore we shouldn't care because you guys don't care as much. Of course we should care. But I think, people are very pragmatic, very philosophical about the side effects and are willing to accept the side effects if it's a drug that's clearly working and helping. But that said, this study's from the Marsden, and they looked at patients who had finished their treatment and they were melanoma survivors. A number of them had had to have steroids, a number of them had had side effects, and when they compared their quality of life to sort of a normal population, there was a significantly reduced quality of life across social, physical and psychological scores on patients who'd had immunotherapy. So it's really important that we try and minimise the side effects because it is impacting on people. And this is data from Germany where they asked patients if they wanted adjuvant treatment. And this is the list of reasons people gave as to why they didn't want it. And perhaps unsurprisingly, older patients and patients with lots of other diseases or comorbidities turned it down. But number 2 and number 3, fear of adverse events, fear of impaired quality of life. And I'm sure, like I said to you, I'm going to make it all sound really awful because I'm telling you all the awful things that could happen. So it does create a lot of anxiety with people. And I've said to you that we give steroids. Steroids have their own side effects. They can make you have a moon face, put on weight in certain places. They can increase your risk of diabetes and osteoporosis. And you're on steroids for a long time if you have side effects, if you have autoimmune side effects, potentially up to 3 months of high-dose steroids. And there are hidden costs. I think for you guys that have had side effects, they're not quite so hidden. You're very much aware of them because you've got the physical side effect, but then you've got an emotional toll. You've got impact on relationships with your family and your friends, whether or not you can go to work. You're more reliant on healthcare. You're having to drive to the hospital all the time. You have to be available for your scans and your blood tests. And what you thought was going to be a year of adjuvant treatment has suddenly turned into 2 years of monitoring for whatever it is. You have to take a tablet for the rest of your life. And there's a big financial cost. And what you're looking at across the bottom is different European countries and the amount of extra financial burden that having immunotherapy has meant for patients. Increased holiday insurance, that's a big deal, isn't it? That's a big deal. Increase the paying for the hospital parking, having to be available for your hospital appointments so you can't go to work, paying for extra childcare if you haven't got grandma around the corner to look after your kids while you go and have the treatment. So there is a lot of problems outside what you might traditionally feel as a physical problem when people get side effects. Okay. So what are we going to do about it? We're going to do something about it, haven't we? We can't just, we need to try and improve the situation. So the easiest way to avoid a side effect is not to have the drug. So some of you may be aware of this trial. Some of you may have been in this trial. So the Detection 2 study, which is being led by Becky Lee and Paul Oregon at the Christie, to say, can we better determine who really needs the treatment or not in the adjuvant setting? Because as I've explained to you, a lot of people have treatment in that setting, they didn't need it. So they're looking to see whether you can monitor patients with cell-free DNA and look for mutations in cell-free DNA to monitor patients rather than giving them treatment. So that would be brilliant. So if we can find some more accurate tests, this or other tests, to determine who really needs that adjuvant treatment and avoid toxicity in the people that don't, that would be great. And you've heard, again, the importance of clinical trials to try and help prove what works and what doesn't. And, big thanks to everybody in the room who's gone into a clinical trial. So not everybody is having treatment in the adjuvant setting. Not everyone's lucky enough to be able to say, it's okay, I won't have the treatment. So what can we do, or can we do anything to try and work out who might be more likely to get a side effect. Now, this slide is deliberately busy. I don't expect you to read it all. It's to say that there's a lot of work in this space to try and see, is there a nice blood test you can do that will say you've got a 90% chance of getting arthritis if we give you immunotherapy? Is there a blood test we can do that tells you that you might get any type of toxicity? And there's nothing in the clinic at the moment that really is very helpful for that. I'm going to mention the gut microbiome because you have to if you're doing a talk about immunotherapy. It's kind of the law. So the gut microbiome may also affect how you respond to immunotherapy, what toxicities you've got, whether you're going to get colitis. And I just want to be a big plug for Heather Shaw, who did a talk here a few years ago. Really great talk on the microbiome. It's still available on YouTube if you search for Heather Shaw Melanoma Focus. These are ways that we can see if we can determine who's more likely to have a toxicity. Now, again, I can't really do very much about that. If you've got metastatic melanoma and I say you've got increased risk of toxicity, well, we're still going to have the treatment, aren't we? And so I guess the next point is to try and work out whether we can give you something to reduce the risk of the toxicity. The answer is not yet, but there is work to say, well, can we sort of cut off the immune response that's causing the toxicity and maintain the response that's helping your cancer die? And there's some work in this space. Hopefully there'll be more work to be able to then say to a particular patient, yes, you need treatment, you're at high risk of toxicity, but I'm going to give you this to reduce the toxicity and still make the cancer work. But we don't have that yet. So just in the last few minutes, Imogen, I will, I'll just say, so right now, the most important thing is for patients to be educated about what the side effects are, because whilst we do educate healthcare professionals, a lot of GPs, a lot of people in emergency departments, they might not have ever seen anyone with metastatic melanoma yet on immunotherapy. And so it's really important that we educate everybody about these side effects. And because some are really weird and because some are really rare, it is really important. There's an oncology team. We're educating patients and we're using our acute oncology teams within the hospitals to help support patients. And I know in a lot of places, and certainly at our hospital, we have a hot clinic, we have a helpline, we try and avoid our patients going to anybody else other than us, so that we can, because we know how best to manage some of these toxicities. As I've said, we need to continue researching in this area, and so if there is a clinical trial available for you, then please consider going into that, because that's how we're going to improve things. And another plug for Melanoma Focus to say there is a load of videos on there. Susanna's already shown the website, and there's some great videos about how immunotherapy works, how targeted treatments work, and a lot of things out there. And the Immunobuddies podcast, so this is Anna Olsen-Brown and Ricky Fraser, who are melanoma oncologists in the UK. They have a podcast which is for healthcare professionals, but I think around episode 56 to 60 is for, it's on the website, but you can listen to those, and those are the patient-focused podcasts about immunotherapy. So, just in summary, so the side effects are really important, and they can be permanent, they can occur later, and they can cause some significant long-term issues. It's really important that we all educate ourselves, and you help educate healthcare professionals who may be less knowledgeable or familiar with these side effects. And as I've said again, and I can't say it enough, studies are really important to try and help improve this. We do need some agents to reduce the toxicity, and I've mentioned steroids briefly, but there's a whole other talk about how we would manage patients on steroids or other immunotherapies, immunosuppressants, and how we would support those patients and help reduce the toxicity related to the treatment for the toxicity. And these long-term effects need a lot of input. So I'm not a gastroenterologist, I'm not a respiratory physician. So if somebody's got bad colitis that isn't settling down very quickly, I need help from a gastroenterologist. And we may need some long-term clinics with MDT approaches to help support people. So just to finish, I've made immunotherapy sound really horrible, really scary, and lots of problems. And there are challenges, but it is a great drug. They are great drugs. This is George. He's always been very keen that you will see him with me at this point. George came to me many years ago. We gave him a dose of chemotherapy, it didn't work. I said, oh, we've got this new drug, it's called ipilimumab, should you have that? He said, yeah, can you sign my life insurance if I'm going to die in 12 months? Of course you can. Signed his life insurance, got his life insurance out. I'd treated about 8 or 9 patients with ipilimumab, it hadn't worked. This is George. He had 4 cycles of ipilimumab. He didn't have a single side effect. His cancer melted away. This is definitely before COVID because I'm wearing real clothes rather than scrubs. And this is his visit at year 10, and I'm discharging him from clinic. Immunotherapy is amazing, and it has completely transformed the treatment of melanoma. Thank you very much.